as Stephanie comes up, Jessica just came up and reminded us that you can register for Fuse in just a few minutes if you walk out to the right in the hall here at the Fuse booth. And if you want to do it now, she's fine on that, or you can wait to the end. So I'd like to introduce Stephanie Jones, who's an anesthesiologist from Beth Israel Deaconess, who's joining us today. And Stephanie is the creator of Module 11, which is the module in Fuse that's on implantable electronic devices and how we use surgical energy-based devices in those patients. Stephanie, thanks for coming.
Thank you. Thanks everybody for hanging in there. We're in the home stretch. I noticed when I was looking at my slides this morning, I managed to leave my name off, which I just called me anesthesia, right? That works anyway, so we're in good shape. I have no conflicts that are relevant to this. I do want to acknowledge Dr. Rosner, who is the co-author of the module online. He is the true expert for this content, taught me most of what I know, and he's fighting a very serious illness right now, so we wish him well. There are lots of things that can be implanted in patients. We're going to be talking primarily about cardiac implantable electronic devices, pacemakers, and ICDs, but you can see there are many things that your patients might come to the OR with that are relevant when it comes to surgical energy. This is an old slide which really sort of emphasizes the wiring. That's an ICD on the right and a pacemaker on the left. Most people don't have anything quite this significant anymore, but you can see lots of possible wires that can conduct your energy. And there are lots of patients floating around with these devices. Currently, about at least 3 million patients with conventional pacemakers, an additional 750,000 placed per year, and ICDs in the order of about 300,000. And now 10,000 ICD implants per month, according to a Heart Rhythm Society paper from a couple years ago. And by 2020, we expect about 670,000 patients walking around with these devices intact. Many sources for electromagnetic interference in the OR, and actually at the end of this presentation, I'm going to talk about a new one briefly. We're most concerned about our monopolar electrosurgical devices as well as endoscopic devices, as Eddie just talked about. What sort of factors are going to determine the effects of EMI on your cardiac devices? So the intensity of the field or source, the frequency and waveform of signal, the distance between the source and the CID leads, basically where are you working, and the orientation of the leads with respect to the field or source. So what power are you using? What mode are you using on your device? Where are you working? And how are things oriented? There are many potential effects of EMI on the cardiac devices. The most important really to think about is the first one, which is inappropriate inhibition or triggering of pacemaker or defibrillation. Now, most of the new devices are very well shielded, so they can, for the most part, filter out a lot of the noise, but the closer you are to the device, again, the higher the energy, going back to using the lowest energy possible, which almost all our speakers have emphasized, you do have to think about these things. So the pacemaker is going to interpret your surgical energy as a cardiac signal. So if somebody is pacemaker dependent, if their device is looking for an intrinsic cardiac signal, sees this electrical signal, it says, hey, the heart's working, I don't have to do anything. You can actually end up cutting the pacemaker signal to the patient. And for an implantable defibrillator, even more important, it's going to interpret that nice shock as some VFib and potentially defibrillate the patient inappropriately. There's other things that can happen, again, much less common, things like unintended asynchronous pacing, potentially reprogramming, though again, not particularly common in newer devices. You can directly damage electrical components if you're close enough. Again, hard to do, hard to damage the pacemaker generator itself unless you're very close with your energy source. You can directly conduct the electricity through the lead to induce VFib or atrial fibrillation. And again, by conducting energy, you can potentially have thermal injury damage at the lead tissue interface. And that's something that's going to present probably a couple days or more after the procedure, so it may be an issue where the patient is not getting their appropriate stimulation by their pacemaker because you now have scar tissue actually in the cardiac tissue. What do you need to know if you have a patient coming in for surgery who has a CIED? You want to know if it's there. You want to know what it is. Most patients have an ID card. Barring that, you can look at a chest x-ray. There's identifying information. You really need to know if they're pacemaker dependent, if they have a pacemaker. That's really where it becomes quite relevant for the anesthesia providers and others to know that if you are planning on using an electrosurgery device, that it might really matter for this particular patient. And what is the device function? So what is it doing for this particular patient? Is it just a backup? Is it something where they are definitely requiring pacemaking activity? All of this is best derived from the physician who put in or who is monitoring the pacemaker. So what you really would like in the ideal world, and I know this is often not the ideal world, is to have your patient get the information from their cardiologist with the context of what procedure are they having and what energy device are you planning on using. If you're taking somebody's toenail off, it doesn't matter. If you are doing a mastectomy on the side of the pacemaker generator, that might matter. Abdominal surgery, somewhere in between. Quick review of the codes, really quick, all right? So remember, going back to wherever you learned about this before, the most common things you're going to see are the first three letters, so that what chambers are paced, what chambers are sensed, and what is the response to sensing. So again, we're worried about the sensing. If the pacemaker thinks it's being paced when it's has an intrinsic rhythm when it's not, it might be inhibited and not pace the patient when they're supposed to. You will often see people in things like DDD mode. If they have a biventricular pacemaker, that means it's going to be dually sensed, dually inhibited or paced. What we often do on somebody who is pacemaker dependent is put them into an asynchronous mode, which would be a DOO or a VOO, which means they're going to get paced no matter what happens. So that's sort of the fail-safe. The fourth column is rate modulation, which is more common in newer devices. It allows for a separate rate if somebody, let's say, is exercising. It'll pick the rate up. It'll often be detected by bioimpedance, so if their respiratory rate increases, it'll increase their heart rate. That's something that we often want to turn off for the OR because you might not want an 85-year-old patient with a heart rate that's elevated through the entire procedure, which can sometimes happen through not so much the surgical energy, but often the anesthesia ventilator can trigger this. So how likely is EMI to occur? The best thing is if you guys can use a bipolar or an ultrasonic, I really don't have to worry about it. But that's not often the case. And if you do have to use monopolar device, going back to, again, what everybody else has said, unblended cut is better than blend, which is better than coag. Should pacemaker be reprogrammed to asynchronous mode? If the patient is pacemaker dependent, then that is likely a good idea. It is not without risk, however. You can have an RNT phenomenon, putting them into a VFib or VTAC. So you have to sort of weigh what's the risk of the patient having a problem with their pacemaker versus a problem with an induced arrhythmia. I already mentioned considering suspension of the rate adaptive functions. ICDs need to be suspended, okay? You do not want the patient getting shocked. You want to have defibrillation and temporary pacing equipment available if you do deactivate somebody's ICD. I'm going to skip that in the interest of time. Often the fail-safe is people say, just put a magnet on it. And unfortunately, I think we're a little bit casual about that, and that's often because either the electrophysiology service or someone else who can reprogram their pacemaker are not immediately available. If you put a magnet on a pacemaker, you will usually get an asynchronous mode, but it's highly variable by manufacturer. It can also be affected by the remaining battery life. So you may not get the response that you think you're going to get. If you have a defibrillator, the magnet will usually not alter the pacemaker function. It will usually turn off the defibrillator, which is what people are looking to do. But again, if you're pacemaker dependent with a dual device, you may, again, need to actually reprogram it in order to get the result that you want. And there's a couple case reports of a magnet going on an ICD, turning off the ICD, and when the magnet was removed, the device did not reset, and the patient was effectively left without their ICD activated. Something to keep in mind. Monitoring is important. The EKG will show noise. I'll show that on the next slide. So you need to have some sort of waveform in order to monitor perfusion. For us, that's usually a pulse ox waveform, very easy to see, or if they have an arterial line, that works as well. And here you can see in this figure, you can see where the device is activated. You get a nice flat line on your arterial line on the bottom there. And once the EKG resumes, and you can see the pacemaker spikes there, the arterial line comes back. So you need some sort of visual cue that you're actually perfusing the patient. For monopolar devices, you want to try to make sure that the dispersion pad is placed such that the current's not crossing directly through your pacemaker. It is not mandatory to put the dispersion pad on the thigh. I know that's where we want to put it, but if you're working on a thyroid or working taking something off the arm perhaps, you can put the dispersion pad in other places. It can go on the shoulder, it can go on the back, okay? So keep in mind where your current is theoretically going before you just slap the dispersion pad on the patient. You want to keep everything as far away from the generator and leads as possible. In general, if you're working below the umbilicus, you're probably fine, particularly if you stick to lower energy levels. So you can be a little less worried about that if you're doing hernias or other operations. But that's a general guideline, not a hard and fast rule. Okay. And we'll skip that. I want to show, I'm going to skip the radiofrequency ablation since that was covered, other than to say that it's basically a monopolar device on steroids, so you really do need to be careful about where things are going. We'll skip that as well. I just want to show this one case that Rosner sent to me, and this is actually a advanced endoscopy case. It's an endoscopic mucosal resection. This was a larger patient. These are done in sort of a sloppy lateral for those who are not familiar. And BMI of 34, had an ICD. They put a magnet on it, but given the patient's position, it probably wasn't in good contact with the device. And what you can see here is this is where the device is sensing the EMI. It's declaring VFib in its little electronic brain. It's charging here. And this is with the proceduralist just doing this short burst that we all think is okay. However, now that it's charged, it gets one more short burst and defibrillates the patient, okay? So again, this short burst concept of using short bursts of energy isn't necessarily preventing this. You really do have to make sure the ICD is off. And really quickly, new technology. If anybody's using the wands to detect sponges, this is a case that just came out 2 days ago where it actually interfered with a temporary pacemaker in a cabbage. When they were doing the sponge count, they waved it over the patient's chest and turned off the pacemaker. So there are other sources of EMI in the aura now that we need to worry about. And there you go. So most of this stuff is in the online curriculum, so please go ahead and take a look at that. And those are my take-home points, and I apologize for the running a little late here, but thank you for your attention.